Hello everyone, my name is Karan Chabra. I'm one of the residents at Beaumont Hospital Royal Oak at the Department of Internal Medicine, and I'll be presenting a case of Eustachian valve endocarditis which was caused by Staphylococcus parentgopheri and got complicated by Dress syndrome. Eustachian valve is an embryological remnant that lies at the junction of the inferior vena cava and the right atrium. And endocarditis involving the Eustachian valve is extremely uncommon and is usually associated with risk factors like IV drug use, central venous catheters, and mechanical devices such as pacemakers. Staphylococcus parentgopheri is a coagulase-negative staphylococcus species that was first isolated in 2002. To the best of our knowledge, there has been only one other case report of infective endocarditis caused by this rare bacterium. On to the case description. We had a 65-year-old male patient with past medical history of non-ischemic cardiomyopathy. His ejection fraction was 25%. He also had a cardiac resynchronization therapy defibrillator device in situ, which was placed 11 months prior, and also had a history of AFib. He came to the emergency with complaints of a blister formation over his CRT pocket side, which was on the left side of his chest. After evaluation in the ED, we sent his blood cultures, and he was started on IV vancomycin. Blood cultures 2 days later was positive for Staphylococcus parentgopheri, and a transesophageal echocardiogram revealed presence of vegetation on the Eustachian valve, which was measuring around 1.1 times 0.5 centimeters. We consulted electrophysiology department, who then proceeded to do laser lead extraction of the CRT system, and 8 days later they subsequently did a CRT reimplantation with the pocket side, this time on the right side of his chest. We placed a PICC line for the patient so that he could get a 6-week course of IV vancomycin, and he was discharged in stable condition. Interestingly, 10 days later, the patient came back to the ED again, this time coming with a generalized maculopapular skin rash all over his body, and he had leukocytosis and significant eosinophilia. Given the clinical context, we diagnosed the patient as drug reaction with eosinophilia and systemic symptoms, which is Dress syndrome. And our dermatology colleagues also agreed with this diagnosis, and this was attributed to vancomycin. We stopped the vancomycin and switched it to daptomycin for the remainder of his 6-week course. Also, we had to give patient high-dose steroids for the Dress syndrome. He was then subsequently discharged, and he has been recovering well since then. So the guiding principle for management of implantable electronic device, that is CIED infections, include complete removal of the device despite the well-recognized complications of lead extraction. Now, if these infections get complicated by valvular infective endocarditis, then the duration of therapy must be for a minimum of 6 weeks. Another interesting point in our case was the presence of Dress syndrome, which is, although rare, but potentially life-threatening drug hypersensitivity reaction. And management includes removal of offending agent and the use of high-dose glucocorticoids. Also, delay in recognition of this syndrome can be fatal in up to 10% of patients, since this can involve multiple organ systems like liver, kidney, and also lead to shock. So to conclude, Eustachian valve is an important component of assessment during transesophageal echocardiogram, especially when there are risk factors for right-sided endocarditis, such as in our patient. And physicians involved in the care of patients with infective endocarditis should be aware about the potential complication of Dress syndrome, since vancomycin is commonly used in the management of such patients. And management should involve high-dose steroid use and removing the offending agent. Thank you so much.